Hi there, and welcome to the, this is September 10th, this is September 18th, FSM Practitioner Webinar. This case is from the FSM Masterclass. This is a patient that was brought in on Sunday morning by Debbie Thrall, and this is a real case. We treated her in real time. And so the symptoms and our guesswork and what happened are kind of what we did. And then if we have time, I've got another couple of case reports to present. But this one was fascinating. The slides I made that day, so they're a little bit abbreviated. And here's the patient's history. She was rear-ended in January of 2013 at about 35 miles an hour. She was in a small vehicle hit by a larger vehicle. Symptoms and her diagnoses. Her diagnoses are kind of bizarre because some of them don't actually fit what she has. Her scapula was winged, which doesn't even begin to cover it. It was completely winged. It was posterior, elevated, winged, and rigid. Her biceps is contracted so she could not straighten her arm. When I say the scapula was rigid, it is that when she laid down on her side or when she was seated, you could not move the scapula even a 1/16 of an inch. It was completely rigid. The muscles regulating the scapula were all spastic. Her biceps were spastic and contracted, contractured. It's kind of like dealing with somebody with a stroke. She did not have a head injury, was not concussed. Her symptoms started within a couple of days of the accident, I think. She was diagnosed with a brachial plexus injury, long thoracic nerve, which involved the serratus anterior. Her rhomboids were completely atrophied, like they're just not functional. The trapezius, the entire trapezius is gone. It's atrophied. There's no middle trap, there's no lower trap. The upper trap, if it was anything, was kind of hard to tell because everything up in her neck was sort of spastic. Her head was upright, no torticollis, but her levator and the muscles that attach to the upper scapula are spastic, just completely rigid. Biceps are spastic. Her pectoralis major and minor are spastic, like rigid spastic. We're not talking trigger points, we're talking spasticity. So this is something I've never seen before. She has vagus dysfunction, so supraventricular tachycardia. Her heart rate has been consistently above 112, sometimes as much as 120, rarely below 100 in the last 4 years, since 2013. Myasthenia gravis is a diagnosis that she had because of some muscle weakness. Think of myasthenia gravis as a loss of immune system regulation that will steer you towards the vagal contribution to immune system regulation. She had constant nausea and vomiting every time she ate, so pretty much gastroparesis. She lost 45 pounds in 2 months in, I think, 2014. So the vomiting, gastroparesis did not start immediately. That took about a year. And then the nausea. So this is the vagus. Accessory nerve injury. Her upper trap was, to the extent it was present, it was spastic. However, the lower and middle trap were just gone. And yeah. So, and then the accessory nerve contributes to the cervical plexus. So that's what we saw. Her shoulder blade was completely rigid, spastic, did not move. pec major, the levator scapula, and the biceps were spastic. The pec minor, the deltoid, and the rhomboids were atrophied. They were just gone. It was weird. She had skin sensitivity when I finally got around to palpating her abdomen, where she said she was nauseated and tender. She was painful down there, just below her sternum. It was T5. And we'll get to that. That was actually the thing that was easiest to fix. She had TMJ, non-painful, not clicking, but bite dysfunction, and that we found because we had Simon Yu was here for the master class, and he did electrodermal testing on acupuncture points, and when he corrected the TMJ with a little sugar packet, her points improved. Her diagnosis was cervical dystonia, but that's wrong because her cervical spine was fine. She was not side bent, she wasn't rotated. It was not cervical dystonia. It was scapular dystonia, spastic upper trapezius, long thoracic nerve dysfunction. The serratus anterior was completely non-functional. She had scapular dystonia. It's where there is central denervation of the muscles that cause it to be spastic. It was unlike anything I've ever seen, to tell you the truth. When you palpate the rest of her, she was spastic in her quadriceps, in her left thigh muscle was tight way at the top. It was just like a guitar string, like a bass string, really tight at the rectus femoris and where it attached to the ilium and the sartorius to some extent. Adductors, which are usually what you think of as being tight or spastic when there's a cord injury. Adductors, brevis was a little tight, but all the rest of the adductors are completely normal. And that's unusual. It's unusual for the quadriceps to be the problem. But rectus femoris and then the quadratus lumborum, the lumbar spine on the left, was very, very, very tight. So that's what faced us. Pain level was 5-6. She's pretty stoic, so it's probably closer to a 6 or 6-7. She was on opiates, so the treatment started with 43 and 46 because she was on, can't remember which of the opiates she was on. Oh, I know, she was on buprenorphine. It's like Suboxone without the naloxone. So it's buprenorphine, which is an opium or morphine derivative. 43 and 46 with 10, the spinal cord. And why would you do 10 as a tissue? Because spinal cord is what's causing at least the lower extremity spasticity. So that ran about 2 to 3 minutes a piece. We had 2 units on her, 3 at one point. Unit number 1 went neck to waist, and we did 81 and 10 on that unit from neck to waist. It could have gone neck to feet. We treated her sideline. So I think we had neck to waist, 81 and 10, and that started taking down the spasticity in the quadratus lumborum and in the quadriceps. So what you're increasing is descending inhibition secretions in the spinal cord. So this whole patient is an introduction to the concept, if it's new to you, of spasticity. What causes spasticity? It is loss of descending inhibition. We would all be spastic unless it was for the descending inhibitory impulses coming down the nerves from the spinal cord to make them not spastic. So 81 and 10, spastic lower extremity, and we had the hope that perhaps 81 and 10 would extend to reducing spasticity in the upper extremity as well. Unit number 2 is neck to waist, and 94 is the accessory nerve, and we were hoping that, so on a normal patient, you run 40 and 94 to, you we run 40 and 94 to reduce upper tract tightness and tone in a patient with normal tone. This is a spastic accessory nerve, right? So 81 and 94 is to increase secretions in the accessory nerve to try and reduce spasticity in the upper tract and try and alleviate the atrophy in the middle and lower tract. Marilyn Miller has a case of accessory nerve trauma that resulted in atrophy of the entire trapezius muscle, and she has before and after photographs of how we reversed that in about 45 minutes. And it was 81 and 94. If you think of 94 as the origin of the accessory nerve, increasing secretions in the medulla is going to increase secretions in the accessory nerve if that frequency is correct. And in point of fact, that's what it started to do. So 81 and 10 started quieting the spasticity in the QLs and the rectus femoris. 81 and 94 started quieting the spasticity in the upper tract and started kind of bringing back some flexibility in the middle tract. We had a pulse meter on her when we started treating 109, the vagus, and we switched to 81 and 109, increasing secretions in the vagus, and the vagus innervates the immune system and the heart and the lungs. She can't go for a walk. Aside from anything else, her heart rate starts at 112, and she has no ability to increase her respiratory capacity. So when you increase secretions in the vagus, you quiet the heart rate. And we'll talk about this in a second. It actually might be a good idea to go to those slides right now. Let me do that. Let me go to the other slide presentation. Can I do that, Kevin? Let me go to the other slide presentation that was done by Diana Cross, and show you what she presented about the vagus nerve, because it's what got me started thinking about this. And I got this slide presentation from Diana Cross on the Sunday, and then the very next week we're treating this patient with vagal nerve dysfunction. So that was pretty fun. She collected data on the use of vagal nerve stimulators to treat inflammation. So this is in rheumatoid arthritis, and the vagal nerve stimulation reduction in interleukin 6, 8, and 17. So the course of the vagus nerve, if you look here, okay, it starts in the pons, it starts in the medulla actually, it goes through the jugular foramen, it goes to, there's branches to the pharynx, affecting swallowing, branches to the carotid sinus, and that affects heart rate, branches to the larynx, and that affects your voice, branches to the lung, the heart, the spleen, the liver, the gallbladder, the stomach, the kidney, the small intestine, and the proximal and distal colon. Okay. Now, vagus has sensory functions, sense of taste. And once again, these slides and this work is from Diana Cross. Sensory functions of the vagus: sense of taste, feeling of hunger, feeling of gastric fullness. So if you have patients who say, I'll eat and I don't feel full, that's the vagus. So have they had some sort of neck injury or inflammation that affects their ability to feel fullness? Because the vagus joins with the cervical plexus at some point. It runs right alongside of it in the neck. And if your vagus is dysfunctional, are you going to feel a sense of gastric fullness? And the answer is no. Abdominal pain and discomfort are sensory functions of the vagus. Parasympathetic stimulation of the vagus nerve increases muscle tone, strength, and peristalsis of the intestines, and thereby intensifies motor action. So patients who are constipated need to have the parasympathetics and the vagus addressed. Motor functions, swallowing, speech, these first two in the list are the main functions of the vagus nerve. That's interesting. Swallowing and speech in the pharynx and the laryngeal branches, or pharyngeal branches, and laryngeal branches. There's the larynx and the pharynx. Swallowing and speech are the motor function. Gastrointestinal movement slows the pumping of the heart and causes constriction of the bronchi. So vagal stimulation causes bronchial constriction. Increasing secretions in the vagus slows the pumping of the heart. The motor functions are gastrointestinal movement. The sensory functions include sensory to the brain that tells it what the gut is doing. I guess that's why it's a sensory function, because it seemed like that would have been a motor, right? Anyway, sensory afferents are reporting into the brain at the medulla. And this is what Harry was talking about when he said that the medulla regulates the immune system and all autonomic functions, because that's where the vagus starts. So there is general and auricular branch of the vagus nerve. So your ear canal, the external auditory canal, is a direct contact connection. It is a place to directly connect to the vagus. You put a wet towel or an alligator clip on a piece of wet cotton and put it in your left ear canal, and you will affect the left branch of the vagus. What else? So the fourth and sixth arches of the vagus: sensory, visceral sensory, branchio, so bronchi, sensory and motor intrinsic muscles of the larynx, parasympathetic, superior and inferior cardiac nervous system, cardiac plexus, brachiochemoreceptors. So these are the functions of the vagus: parasympathetic, cardiac branches to the thorax and the abdomen, where it affects muscles of the pharynx, larynx, the palate, and the upper esophagus. Visceral sensory to the thorax and the abdomen, taste, I'm not sure what that word is, and the baro and chemoreceptors. Sensory, the larynx, pharynx, and small areas of the skin. Really? Small areas of the skin. Can I do this? No. That little thingy just gets in the way. In a nutshell, the vagus nerve consists of a complex network that regulates one's neuroendocrine immune axis, mood, pain, and memory. So it is intimately involved with all of our functions: motor, sensory, digestion, cardiac, bronchi, speech, and this branch that goes to the external auditory canal is what makes you cough, right? What makes you cough when you're cleaning your ears with a Q-tip, right? I really need to, Kevin, how do I move this without turning this off? I need this little box to move. And every time I click on it, it kicks me out. So I don't know. Okay, I give up. So eardrum and behind the ear. So that gives us access, direct access to the vagus nerve. It serves as a control center that integrates incoming sensory information and responds with appropriate adaptive modulatory feedbacks. So this is fascinating to me. So how does So the vagus is one of a number of neuroimmune reflexes. So the vagus goes to well, if there's an axon reflex that affects nociceptors inform the vagus, and the vagus and create neuropeptides which cause the vagus to intervene with the spleen and direct inflammation. Inflammatory reflex is modulated by acetylcholine. It stimulates the macrophages through the celiac ganglion. Neuromodulation of antibody responses is modulated by acetylcholine, the splenic nerve, norepinephrine. So your stress response, just the stress response, acetylcholine and norepinephrine, the stress response can modulate antibodies and inflammatory response. The vagus nerve stimulates the adrenals to create dopamine, and that can create inflammation. Vagus nerve, acetylcholine, stimulates macrophages, and the enteric nervous system, norepinephrine, stimulates a different kind of macrophage. Reflex account, gateway for the text. So,
Tom has a question.
Tom
Wait till the end.
Affleck, about this slide?
Tom Patterson.
Oh, Patterson.
Yeah.
If he can wait.
Yeah.
Or do you want to go now? What's the question?
I'm Vector.
What? Vagal?
Cool. Vector?
I don't know what the word is, Tom. What are you talking about?
Never mind. We can handle it later.
Yeah, we'll have to do it later. So the vagus is one of a number of neuroimmune reflexes that keep inflammation regulated. So if you look at infection, bacteria or viruses, and tissue injury, and then cell debris, those stimulate macrophages. Regulatory nervous system, regulatory mechanisms that keep the vagus, keep the macrophages and the immune system response sort of under control. The macrophages release cytokines and create inflammation. Beat down the viruses, bacteria, help heal the tissue by causing inflammation that causes scar tissue. So now you have bacteria, viruses, and cell debris. And if all that works properly, then you go to health. The problem is where the cycle is not regulated properly by the vagus, and you get non-resolving inflammation in rheumatoid arthritis, arterial sclerosis, inflammatory bowel disease, MS, certain cancers are a result of non-resolving inflammation, swelling, loss of function, tissue injury, pain, anorexia, fatigue, shock, and fever. That's when the inflammation is not resolved and it is perpetuated, okay? So this signals from this perpetuated inflammatory response report to the brain. PAMPs and DAMPs, I keep forgetting what that stands for, but there's those of you out there that know it better than I do, via the afferent vagus, right? So these peripheral cytokines feed into the vagus feeds out to the celiac ganglion, to the splenic nerve. The vagus releases norepinephrine and goes to the spleen. That secretes acetylcholine, which stimulates the vagus, which stimulates the spleen to produce more inflammatory macrophages, and that's the cycle. Well, the problem is that the dampening effect of the vagus to regulate, so the brain sends the stimulus down the celiac ganglion via the efferent vagus to quiet from the celiac ganglion to T cells in the brain, which in turn signal to the macrophages there to settle down, okay? So vagal nerve stimulation, vagus nerve to celiac ganglion. I have to study this a lot more before I get good at it, but you're seeing what I saw by way of Diana Cross. She's going to be at the symposium in 2019. Adrenergic splenic neurons go to the macrophages, acetylcholine and norepinephrine are the guys, which result in attenuation of cytokine production by those macrophages. So peripheral injury turns it on, and the vagus is supposed to regulate it or turn it off when it is no longer needed. So the vagus quiets splenic macrophages with acetylcholine, and the peripheral signals increase inflammation. I think it said with norepinephrine and dopamine. So it's this balance between the vagus, the spleen, the macrophages, injury, inflammation, infection, and lack of vagal regulatory tone is part of what happens in this non-resolving inflammation or sickness syndrome, so-called. And that attenuates inflammation. So if you stimulate the vagus, increased vagal activity causes increased heart rate variability, and thought bubble. Let's take this thought bubble a little further. Diana Cross is the thought bubble person. So what they did was they implanted a vagal nerve stimulator, right, that just used milliamperage current to cause the vagus nerve to fire. One of their researchers has shown that the effect can be achieved transcutaneously using just microcurrent. So a transcutaneous vagal nerve stimulator based on the rationale that there is an efferent vagus nerve distribution on the surface of the ear in this little auricular branch, you can get at the vagus directly. So 250 millionths of an amp, that's 1/8 of the amount often used to suppress seizures. Macrophages hit by acetylcholine are unable, so it causes the vagus to produce acetylcholine, and macrophages hit by acetylcholine are unable to produce TNF-alpha for up to 24 hours. And that's what we saw with FSM. So, left side of the neck, external, where's the interesting part? Oh, come on. There is a place in here where she talks about, come on. There's a place in here where she talks about the functions of the left side of vagal anatomy. Where is it? Left side. Oh, come on. The left side does one thing and the right side does the other. Where the hell did it go? Oh, sorry about that, you guys. There is a slide here that talks about the left side of the vagus, what the anatomy does. Right to the soleus. Okay, that is totally annoying. The left vagus, what did I do with those slides? The left vagus is the ventricular branch, and the right vagus is the atrium. So if somebody has atrial fibrillation, it is the right side, and if somebody has ventricular tachycardia, it's the left side. So that takes us to this, our patient here. So we switched to increased secretions in the vagus because she had ventricular tachycardia. Her heart rate was 112. So we did 81 and 109 to increase secretions in the vagus, and her her pulse started dropping from 112. It was pretty variable. It jumped all over the place for a while. And then it finally settled down in between 60 and 70. And what's interesting, she had to empty her bladder at 60 minutes, and that was unusual for her. We treated her, I think, for 2 hours. We added a third unit from neck to waist that ran 94 and 124 and 109. So just to treat the vagus for being busted, because if she had digestive problems, vomiting, constant nausea, and a heart rate of 112, the vagus has been damaged. So we did that, and her heart rate settled down into a pretty steady, so that is 94 and 124 with 109, pretty steady heart rate of between 60 and 70. Then we did neck to brachial plexus with 40 and 396 and started working on the scar tissue between the nerve and the fascia, so scarring in the nerve, 13 and 396. We did 81 and 396 to try and reduce the spasticity. So if you can get appropriate nerve input to different muscles, you can quiet the spasticity, which is a response to denervation. So there's that. 40 and 396, inflammation in the nerve. So you can tell with 13, 81, and 40 all running with 396, it's not like I knew what I was doing. We were just poking around trying to find something that would work because I'd never seen that kind of spasticity. Now, the most tender area that she had was this area in her abdomen at about T5, and that wasn't changing with any of the things we did to the brachial plexus. So I moved the red leads to the middle of her spine at the T4, T2 to T6 area. Positive leads there, the negative leads on her abdomen. We ran 40 and 396, and the epigastric tenderness completely went away in something under 2 minutes. So after a bathroom break, we tested the meridians, and Simon found that the left-sided bite was involved, which is kind of where everything was damaged, right? If the left side of the vagus, it regulates heart rate, ventricular rate, the right side is atrial. The left side regulates the spleen and our immune system function, which kind of explains why she was temporarily diagnosed with myasthenia gravis, which she didn't have, actually. So we put a little sugar packet in her teeth. We went back to 81 and 10 and 81 and 94, and those relaxed the trapezius and the upper back muscles. 81 and 109 on the second unit that ran neck to waist. And then the third unit ran from her neck to her arm, if you remember that setup where you wrap the upper arm down to the hand. Then trauma, and then 98 is Christine Allcroft. If you look in the advanced, 98 is for paralysis, and she uses that instead of 321, so we tried that. That seemed to work, sort of stabilized her heart rate down in the 60s, then scarring in the vagus, and we kind of played along the length of the vagus in her neck and her chest to regulate the heart rate more, improve her digestion. 40 and 81 and 13 with 396 from her neck to the brachial plexus. What was fascinating was the trapezius spasticity was reduced. Her scapula became mobile. You could actually, it would translate passively, so you still couldn't move it actively, but you could translate it almost 2 to 3 inches and it would slide forward and back. So the spasticity in the levator and the upper trap were relaxed. The biceps were less tight, but still not normal. She went from 90 to, so 90 degrees of spastic flexion to maybe, depending on how you measure the angle, like a minus 40. So she got an extra 10 to 20 degrees in her biceps. Heart rate was 62, between 62 and 77 during the treatment. She got up off the table and it stayed at 90, which was pretty exciting. And the sensation at T5 was very normal. We were all happy about that. That was probably her favorite, because when sensation at T5 was normal and when 81 and 109 did its thing, she was also not nauseated. So the combination of 81 and 109 and 40 and 396 normalized the sensation at T5 and took out the nausea. So I would say this is the first time I've ever treated anybody with 81 and 109. I've never treated anybody, well, I've treated one other person with ventricular tachycardia, but not where there was such an obvious cervical trauma component. She had damage not only to the accessory nerve, but the vagus and the cervical plexus and the brachial plexus in this fairly straightforward 35-mile-an-hour auto accident. So I swear to God, some very nice medical physician offered to fuse her scapula to her rib cage. Oh, that's okay. We'll just cut those muscles and we'll just bolt, screw, adhere your scapula to the rib cage. It'll be fine. That would get her shoulder blade out of her ear. That would be good. But the word is nobody gets to touch her with a scalpel. We got to see how long this lasts. Debbie Thrall says that the pain in her abdomen has remained gone, and the nausea is gone. The spasticity is back to tight. Take fish oil, 2 grams a day. I was looking for some sort of spinal cord damage, disc herniation, a bulge or something at C5, and she sent me her MRI, and it's completely normal. So I have absolutely no idea what happened to her brachial plexus or why the nerves to the rhomboids and the pec minor and pec major are so damaged. Retreat, so that is not retreat as in go back, but retreat. All of the above, what we did before, 43 and 46 and 4 for morphine with the spinal cord for 1 minute, and then the custom care with increased secretions in the cord, increased secretions in the medulla, increased secretions in the vagus, and reduce inflammation in the nerve. Protocol for fixing the vagus, 94, 321, 9, 98 instead of 321, 124, increased secretions of vitality, 109, cord fix, because some of this spasticity is from damage to the spinal cord somehow. She can have a long track injury that injures the axons in the vagus. How did that happen? That injures the axons in the vagus, or in the spinal cord, and they will die back, which could explain the spasticity that happens over time, has increased over time, and then have the dentist check her bite. So that was our next step with her. I really want to see if I can find that anatomy slide, but I guess I'm going to have to do that the next time. Let me see if I can find it. Because the anatomy was the coolest part of this. Okay. Left vagus, right vagus. I guess you can Google it. Diana had to find it from someplace.
I think we can attach a link.
Okay, we'll put a link onto it. I know the anatomy's there because I got the slide memorized. It's in my head, but I can't. I couldn't find it in the presentation, so that doesn't make any sense. So the next section has to do with a patient where we treated myofascial pain less than successfully, and then what actually happened, and then we segue to Detoxification. This is a presentation I'm doing in Germany next month, actually in November. So it suggests both the specificity of what we do and how you have to think about it, okay? So we treat myofascial pain and scar tissue all the time, right? When we treat myofascial pain, we treat the nerve, we treat the disc and facet, we treat the muscle. For best results, we treat what's causing muscle pain. So you know you can treat the nerve, right? That's 40 and 396. We have a published paper on that. Nerve pain, 40 and 396 is pretty much the easiest thing you treat. It's pretty straightforward. Myofascial trigger points, treat the nerve, treat the muscle, treat the joint, treat the disc, treat the facet, treat the ligaments. 50 cases of cervical myofascial pain, 23 cases of lumbar myofascial pain. And we know that we can dissolve scar tissue. We have the rats, we have the burn patients from Mercy St. John's, and 13 and 77 in the rats liquefied the adhesions in the rat's abdomen. 13 and 142, scarring in the fascia, scarring in the connective tissue, scarring in the nerve, scarring in the blood vessel, created statistically significant permanent increases in range of motion after 3 one-hour treatments, okay? Now, scar tissue precaution, you can't use it when the injury is less than 6 weeks old, so we know that. And you know that when you treat muscles and fascia, you combine it with manual therapy. So that's Kim Pittis. Be sure you look up, and if you see athletes or do sports medicine at all, you want to be sure and look for Kim's Sports Medicine Conference in September. When is Kim's sports seminar? Last weekend in September, and she's going to be in Phoenix, Scottsdale. Find it on our website. Anyway, this is Kim working on an Olympic swimmer, getting his QLs free from the kidney fat pad, and the ureter. Okay, so we know all that works. That should be straightforward. What do you do when that doesn't work? That's when the specificity of the frequencies is both a blessing and a curse, because you have to think. So the patient says, my vagina is scarred from a tear. So she had a vaginal tear when she delivered her second child, and the episiotomy is so painful, I haven't had intercourse since his birth 18 months ago. Can you help me? So her first child was born and was in neonatal intensive care. He was premature. She got pregnant while the first child was still in the hospital. So she delivered the second child 10 months after the first child was born. So in general, dissolving vaginal scar tissue is easy. So I put a glove behind her sacrum, put the graphite glove on my hand, wet the glove, put a PVC glove over that, so it would be a clean procedure, put a little KY jelly on my fingers, and inserted the fingers, 2 fingers of my index and middle finger of my right hand into her vaginal, and felt for the scar tissue. Well, dissolving vaginal scar tissue is easy, but there was no vaginal scar tissue. There was no episiotomy scar. And she said, it's a painful episiotomy. I had a tear. Okay, there's no episiotomy, there's no scar tissue, but it's definitely painful because when I inserted my fingers about another centimeter, I ran into her pelvic floor muscles, and they were totally spastic and very painful to touch. It's exquisitely painful. And they weren't just tight, they were spastic. So I did treat the nerve, treat the muscle, it did nothing. Dissolving the scar tissue in the nerve and the muscle and the fascia and connective tissue did nothing. 10% softening or so in the pelvic floor muscles and no change in pain. Meanwhile, while she's getting treated, the patient is talking. The patient talked while she was being treated. She said, my first child was born early and was in intensive care. My second child was born 10 months after the first child. My uterus never had time to recover. And while I was working on the nerve and the muscle, just from a myofascial standpoint, she got to the point in the story where she repeated that phrase, my uterus never had time to recover. And then it came up again, my uterus never had time to recover. About that time, finally got the message. And you had to ask, if it isn't fascia and it isn't muscle and it isn't connective tissue, why were the muscles in her pelvic floor in spasm? Cerebellum regulates muscle tone. Why would the cerebellum cause the pelvic floor muscles to spasm? What was the cerebellum trying to protect? What is the cerebellum trying to protect by tightening the pelvic floor muscles and preventing intercourse? Here's the pelvic floor muscles, and here's where they are, just below the uterus. My uterus never had time to recover. My uterus never had time to recover. So if you were the cerebellum and you wanted to protect the uterus, what would you do? She's not going to get pregnant again. So they made the pelvic floor muscles so tight that she could not have intercourse. I could not get a single finger through her vaginal opening any place near it because of the spasm in the pelvic floor muscles. So ask yourself, recover from what? Well, what we consider the trauma protocol, recover from trauma to the uterus. So it starts, my plan was to run trauma, paralysis, and allergy reaction. So I got as far as 294 and 34, trauma to the uterus. And the pelvic floor muscles started to relax instantly. And in 20 minutes, with just 294 and 34, they were completely soft and pain-free. Now I ran the rest of it, 321 and 9 and 40 and 970 and 34. And at the end of 20 minutes, the pelvic floor completely relaxed. Intercourse became pain-free, and her third child is now 2 years old. So everything is just fine, thank you. So the question is, how did that happen? If you look at trauma as a pattern stored in the tissue, the body responds to the pattern, right? Trauma is a pattern stored in this tissue. Remove the pattern and the tissue changes. So cell signaling, change cell signaling, and function electromagnetically. How has somebody in 1922 decided that 294 was the frequency to remove the pattern of trauma is totally beyond me. I mean, that's like a whole other conversation that may involve psychics or something, because I have no idea how they decided that. But you change the pattern in the uterus that tells the cerebellum, hey, we're fine down here, don't worry about it, and all of the pelvic floor muscles relax. That's an interpretation. So when you change the pattern, you treat the cause of what's in front of you. So changing this pattern is kind of the basis of everything we do. How do you change elevated heart rate and immune system dysfunction and digestive system dysfunction and not constant nausea and vomiting and hoarseness? How do you do that? You increase secretions and treat for trauma and torn and broken in the vagus. It's an interesting concept, and it's the basis of everything we do. So here's one other one. So we talk about, the functional medicine folks among you, us, talk about detoxification. And we talk about it as if it's a simply chemical process, that these toxins are stored in the tissue and the liver can't process them, and so you have to detoxify the patient by treating the liver, the kidney, do supplements, treat phase 2 and phase 1 pathways, and get rid of toxins. Well, what do you actually mean when you say detoxification, and what are you actually doing when you detoxify a patient? Are the toxins still there? Just like they were exposed to toxicity 20 years ago or 10 years ago or 5 years ago and they're still having problems? Are the toxins still there? So think about toxicity and organic chemical exposure. Organic chemicals are absorbed through the lungs, the skin, and the intestines, right? So you breathe them in, they get on your skin, you eat them on your food, you live in a building that has sprayed for bugs all the time so they get absorbed through your lungs, your sinuses, your skin, and this is kind of what they look like. These are organic compounds, right? Okay, so they go to the liver, and if the liver can't detoxify them, it sends them back out, and they land someplace. They are organic because they're not charged, and they slip right into this lipid membrane, okay? So here's the lipid part. There's little protein tails. That's a transmembrane protein. This is a really nifty image I just got off of internet. So you've got these organic chemicals that are embedded or dissolved in the membrane. And you have integral proteins, you have proteins, membrane protein receptors, and this organic chemical is going to land next to it, and these chemicals are large, and they are heavy, and some pieces of them are polarized. And when they land in the membrane, they can change membrane configuration, membrane protein configuration, and thereby change cell signaling. Cell signaling changes cell function and ultimately health, right? So that's the mechanism. Now the question becomes, are the toxins still actually there? Now if it happened 2 weeks ago, yeah, they're probably still there. It happened a month ago, maybe they're there. But the fact is that these cell membranes turn over on a regular basis. The cells are deconstructed and reconstructed over and over again. The membrane proteins are replaced kind of exactly as they were when it was deconstructed. So the membrane protein receptors that regulate cell function are reproduced, but the toxins are gone after a period of time. The cell membranes turn over and the toxins are removed from the membranes and detoxified and excreted. However, because the receptors are not reconfigured, the toxins are gone, but the signaling that modifies gene expression and cell function is still altered by the effect of the toxin on the cell membrane receptors, right? And to me, that's the only explanation that explains why using the frequencies 57, 900, 920, 225 is inorganic toxins. Using the frequencies to remove toxicity doesn't cause detoxifications as you would expect if you were liberating toxins, right? You run 57, 900, 920 on somebody's liver or their brain or their pancreas or their lungs, and they don't get sick, right? They don't. At least mine never did. They don't get sick. Now you give them support so that their liver works better. You can give them lipoic acid or glutathione or different liver detox pathways intermediates, and to support that in the long run. The 57, 900, 920 changes brain function, changes how the gut works, it changes how the liver works, it changes liver tenderness, changes nerve function, changes how the fascia works, kidneys, lung, any tissue that is susceptible to toxicity, 57-900, 920 changes how it works. But it doesn't cause a detox reaction. The only thing that makes sense to me about that is this. What we're actually changing is cell membrane receptor function that is altered. So it's like the cell protein, this peptide, is like a little antenna, and it gets knocked off kilter by an organic chemical that lands next to it. When you run 57-900, 920, the image I get about that is that those signals are like a signal out to a receiver dish on a satellite or a remote control device that causes it to recenter and find a homing signal. It's like, hey, here we are. This is how to function. Forget that thing that landed next to you. This is what you want to do. It's the only thing that makes sense. So this is probably the most disconnected practitioner webinar I've ever done, but it's been a very interesting and busy week. We leave for Jacksonville tomorrow, and I leave for Jacksonville tomorrow. And for those of you that are listening and in the Jacksonville area, we have a special guest student coming to the Jacksonville seminar, and that would be Jim Osman. He decided that FSM is so fascinating that he absolutely has to take this course. So he is auditing or sitting in as a student on the Jacksonville core seminar. That is, let's see, what else? Resonance effect. I didn't make the ending slides for this. It's been a crazy week. So if you haven't purchased or read the resonance effect, I suggest you get it and see that your patients read it and give it to their friends so that they know what you do and they can help make your practice busier and more successful. What else? Core seminar coming up next March 1st is Jay Shaw. Jay is the reason we run 40 and 10 to deal with spinal and central sensitization. And then the advanced is the second and third, and then we have an instructor training on the 4th. There is one more slide here that was interesting because it makes you think about it. So the uterus story and the toxicity story, you can't fix everything in everybody. FSM is not a panacea, it's just biophysics. But you can't treat what you don't think about. FSM will treat exactly and only what you choose. If the problem is not emotional and you only treat emotions, it's not going to work. If the problem is not toxicity and you only treat toxicity, it's not going to work. If the problem is not the fascia and all you treat is the fascia because that's how your brain works, it's not going to work. So the frequencies actually help tell you what's going on and how to treat patients successfully. So I'm hoping that this has been fun. It's a little bit more disjointed than usual, but I had a good time. I will see if I can find Diana Cross's slide about the left and right vagus anatomy. That's going to drive me a little bit crazy. Join us next month for the webinar. I think we're going to have one, although next month I'm on the road a lot. Yeah.
We'll send out an email. We'll send out an email.
We'll send out an email. Take care and join us on Facebook on the FSM practitioner page, right? Facebook. Frequency specific microcurrent is the Facebook page, and there's an FSM practitioners page, right?
There's
members only group, FSM practitioners
if you're
group.
not a member, just email us.
Yeah, if you're not a member, just email us, and Kevin or I will add you. And that's been really fun. It's actually easier, almost easier to use in the forum. My thanks go to Paris Carbot, who still takes care of the form, and to all the people that are using the FSM Practitioners Group, that has turned out to be awesome. Have a great week, and we'll see you next month.